Hi everyone and welcome to our model on Pharmacodynamics I. In this model, we're talking about one of the first components of pharmacodynamics, which is drug action. And we'll be talking about everything regarding drug action, from the types of drug action to the mechanism of drug action to receptors, which are the commonest mechanism of drug action. And then we'll focus on drug receptor relationship. Pharmacodynamics refers to the effect of the drug on the body. Simply put, pharmacodynamics can be defined as what the drug does to the body, and in contrast, pharmacokinetics on the other hand talked about what the body does to the drug. This would be the reverse. The common components of pharmacodynamics includes drug action, which we'll be talking about in this particular module, drug effect, and then the dose response relationship. The other two components, the drug effect and the dose response relationship, will be covered in a separate module. And this first image depicts for us the concept of pharmacodynamics with respect to the drug action. You could see that at the top left corner of this image, the drug being shown here is Viagra or sildenafil, and this drug is typically prescribed for people with erectile dysfunction. Once you use this drug, the effect of the drug would be shown, or is what is shown in the image on the right, which is penile erection. But how exactly this Viagra is involved in causing penile erection is the mechanism or the drug action of Viagra, which is penile vasodilation. So, drug action asks the question of how a drug is able to perform a particular effect or cause a particular effect in the body. Drug action, in terms of definition, is the mechanism by which a drug produces a desirable and undesirable effect. The key word here is the mechanism by which the drugs tend to act. And as I said before in the previous slide, drug action asks the question of how a drug will be working in the body. We have five major types of drug action, and these five of drug action stems from the fact that drugs typically do not produce a new function in the body. What drugs do is that they either enhance, depress, they replace, or they destroy pre-existing functions already in the body. And this is captured by the fact that we have five types of drug action. These types of drug action include stimulation, depression, irritation, replacement, and cytotoxicity. Stimulation is the first type of drug action. For stimulation, drugs categorized under this type of action are drugs that would selectively enhance already existing activity on specialized tissue. Now, the keywords there to remember for this type of drug action, first of all, is the fact that they selectively enhance specific activities and they do this to specialized tissue. Examples would be a drug like adrenaline working on the heart. The heart, in this case, is a specialized tissue, and adrenaline is going to be increasing a particular function or activity already present within the heart. Another drug is pilocarpine. Pilocarpine on salivary glands. Salivary glands also being a specialized tissue, and pilocarpine working to enhance the activity of the salivary glands. The picture showing us adrenaline. Adrenaline, in this case, works through the type of drug action we call stimulation. How it do its work is by enhancing the typical activities of the heart. On the left side of the screen, you can see a man that's at slump, probably due to cardiogenic shock or due to cardiac arrest. So in this particular scenario, we would want to prescribe adrenaline to this particular patient so that it could kickstart the function of the heart, which is the function of pumping of blood. And this is the reason why we classify adrenaline as a drug under the category of stimulation. The second type of drug action is depression. Depression is distinct to stimulation in the sense that drugs categorized under depression are drugs that selectively reduce specialized or specific activities, and they do this on specialized tissue. So the keyword again is selective um, reduction and also specialized tissue. Examples would be drugs like lisinopril, quinidine, and omeprazole. Lisinopril, for example, works on the specialized tissue of the blood vessels. Quinidine would work on the specialized tissue of the heart, and omeprazole will work on the specialized tissue of the gastric glands. The function of each of these drugs would be to reduce the functions of different organs to which they act. And this picture captures the type of drug action called depression. Lisinopril being the case study. Lisinopril is typically used as an antihypertensive agent. As you can see on the left hand side of the slide, you could see that the blood pressure check of this patient is above normal, it's above 120 systolic and 80 diastolic. She's having a blood pressure of about 180 systolic and 95 diastolic, which shows that she's hypertensive. In the case of this particular patient, you could use lisinopril to drop the blood pressure. Now, the blood pressure is a specific function or physiological function already existing, and it's existing in the specialized tissue of the blood vessel. So, lisinopril would selectively act on blood pressure to reduce it, and it's working on those specialized tissue which we know as the blood vessel. Irritation is the third type of drug action. Irritation involves non-selective noxious activity, and it typically occurs on non-specialized tissue. You can see that this is very different from the first two types of drug action we talked about. For irritation, it's working on non-specialized tissue and it is causing a non-selective noxious effect. Typical examples of drugs that work through irritation are methyl salicylates for joint and muscle pain and bitters on salivary and gastric secretion. And this is an image of methyl salicylate. We typically use it for people, prescribe it to people that are having issues with muscle pain, joint pain, or aches, and they tend to form a relief for this particular set of scenarios. They are going to be working on non-specialized tissues. They work on tissues around the site of application if we're applying them topically, and they typically cause a noxious effect, thereby reducing the pain present within the particular area they've been applied to. Replacement is the fourth type of drug action. Replacement involves the replacement of deficient endogenous substance. Like I said, drugs typically don't form a new function to the body. They just either enhance pre-existing functions, reduce pre-existing functions. They either destroy pre-existing functions or they replace them if they are deficient. In the case of replacement, drugs like insulin and levodopa are drugs that tend to act as replacement. In scenarios or conditions like diabetes mellitus and Parkinson's disease, endogenous substances are usually deficient. In diabetes, we have deficiency of insulin. In Parkinson's disease, we have deficiency of dopamine. And these two drugs, insulin and levodopa, are just replacement drugs to replace the already deficient endogenous substances that are found in the diseases. This is a picture of insulin, and as you can see, presence of insulin in the body produced naturally would help in reducing glucose level, as is shown in this particular part of the slide. If the insulin production in the pancreas is affected or impaired, what happens is that there's a buildup of glucose, and that buildup of glucose will lead to a glucose reading being above normal. And what we can do in treating this particular scenario is by giving exogenous insulin as a form of drug that would help us in normalizing the glucose level. Then finally, we have the cytotoxic action. Cytotoxicity or cytotoxic action involves drugs that selectively destroy cells. Usually, these cells are either neoplastic cells or microbial cells. And the point of destroying these cells is to normalize the functions of the body. Remember that neoplastic cells typically occur in a scenario of cancer or malignancy, whereas microbial cells usually occurs in a scenario of infection. So drugs that tend to perform cytotoxic action are drugs like anti-neoplastic agents such as cyclophosphamide, azidovodine. We can use them in treating cancers. And then drugs that are affecting microbes are examples would be penicillin, which is used in treating infection. This is a picture of cyclophosphamide, an anti-neoplastic drug. And one of the typical cases we could use it to treat would be breast tumor or breast malignancy, as is shown in this particular image. What this drug is going to be doing is going to be selectively destroying neoplastic cells while sparing the normal cells within the body. The mechanism of drug action differs from type of drug action. The mechanism of drug action acts about the how drugs tend to do their work. And for the mechanism of drug action, there are three major mechanisms. We have the physical mechanism, the chemical mechanism, and the biochemical mechanism. So the first mechanism of drug action includes drugs that neither produce chemical reactions nor change cells of the body, nor do they also interact with biochemical structures. These drugs tend to act purely by physical mechanism or physiological mechanism. So drugs like laxatives, like activated charcoal and mannitol, they are all classified under this particular category. Laxatives are used in treating constipation, activated charcoal is used in poison management, and mannitol could be used as an osmotic diuretic. Magnesium trisilicate is a laxative, and just as we said in previous slide, laxatives typically make use of the physical mechanism to perform their action. In the case of magnesium trisilicate or MISMAC, the physiological mechanism it makes use of in performing this action is the mechanism of osmosis. Remember that osmosis, based on physiology, is a concept that talks about the movement of fluid from a region of low solute concentration to a region of high solute concentration. As you can see on the left side of the screen in the image, you have water molecules moving from one particular region to other region. The region where the net movement is occurring is a movement where we have a lot of solute present in. So this is typically how laxatives tend to work. Laxatives would act as the solute in this case, and being present within the GIT, what they tend to do is that they tend to drag fluid from the bloodstream into the GI lumen, and in doing so, they will soften the fecal matter present within the GIT, hence making it easy for excretion of fecal matter to be possible. And that's how we use them in treating constipation. Second mechanism of drug action is the chemical mechanism. In this, drugs that are categorized under this mechanism are drugs that produce chemical reactions in the body. So drugs like antacids, such as sodium bicarbonate, chalating agents like dimercaprol, penicillamine, deferoxamine are also classified under this group. Pyridoxine, which is a choline esterase reactivator, and then cholestyramine, which is a bile acid sequestrant. All these drugs are classified under the chemical mechanism because they are all involved in producing chemical reaction within the body. Typical example of a drug that works with a chemical mechanism is depicted in the picture here. The drug of focus here is Gaviscon. Gaviscon is an antacid, and how it typically would work is that it creates a chemical reaction we call neutralization reaction. Remember that when we mix an acid with a base, the reaction that occurs is the formation of water and salt. And in the case of the drug Gaviscon, which is an antacid, Gaviscon is the base in this case, and then the acid is the gastric acid of the stomach. So in a scenario like this, Pepsi or peptic ulcer, the gastric acid of the stomach would mix with the drug, would mix with the antacid, which is the drug, and as a result would form chemical reaction, which is what we call neutralization reaction. And what happens is that as a result of that formation of water and salts, the toxic effect of the acid on the GIT would be reduced. Hence the reason why we use these drugs in treating peptic ulcer or dyspepsia. Final mechanism of drug action is the biochemical mechanism. For this, this involves drugs that tend to interact with different biochemical structures in the body to perform their actions. Now, these biochemical structures, we make use of the acronym RICE in remembering each of the biochemical structures that drugs could interact with. The R there stands for receptors, I there stands for ion channels, C for carriers, and then E for enzymes. So examples of drugs that could make use of the biochemical mechanism would be albuterol that acts via receptors, lidocaine acting via ion channels, omeprazole acting by carriers, and then captopril acting by enzymes. We'll talk about each of this in the next couple of slides. Now this is a picture of an inhaler. Inhaler typically contain beta 2 agonist. In the case of this inhaler, the drug that is present within it is albuterol sulfate. Now, albuterol sulfate is an example of a drug that acts through the biochemical mechanism, particularly acting on receptors. As you can see on the left part of the screen, you could see that the particular receptor that albuterol will be acting on is what we call the beta 2 receptors. And in doing so, they tend to activate the G protein coupled mechanism, and as a result, they lead to bronchodilation or smooth muscle relaxation of the lungs, hence relieving the symptoms of asthma. For this picture here, on the right side of the screen is a picture of an injection of a local anesthetic agent like lidocaine into the gum, so a dental procedure. Lidocaine is an example of a drug that works through ion channels, particularly working through sodium channels. And the idea behind this is that lidocaine or local anesthetic agent binds on this particular ion channel and blocks the ion channel, thereby non preventing the formation of action potential within the nerves, and thereby producing analgesia or producing an anesthetic effect around the site of injection. For your exam, it's also important to note examples of drugs that act through ion channels. So we have quinine or quinidine and procainamide acting through sodium channels alongside the local anesthetic agents like lidocaine. We have nifedipine, verapamil, and diltiazem acting via calcium channels. So they're calcium channels inhibitors. We have drugs like amiodarone and sulfonylureas, which are antidiabetic agents. Drugs like glyburide, for example, or glibenclamide. These drugs tend to act on potassium channels. And then we have drugs like benzodiazepine, which would act on the chloride channels that are typically referred to as chloride channels activators or sometimes inhibitors. Now the picture on the screen here on the right side is a picture of omeprazole. Omeprazole is a typical example of a drug that acts through carrier proteins. The particular carrier protein that omeprazole acts on is the proton pump. Proton pump is a carrier found on the parietal cells of the gastric tissue, and proton pump is involved in pumping protons, which is hydrogen ions, out from the parietal cells into the lumen, and also pumping potassium ions into the parietal cells. The proton pump is an example of a carrier protein that also has an enzyme mechanism to it. So we could say that omeprazole is a drug that acts on a carrier protein alongside acting on an enzyme because it's an enzyme component to the proton pump. For your exam, it's also important to note the other examples of drugs that act through carriers. So drugs like hemicolinium act on the choline carrier, so it's a choline carrier inhibitor. Drugs like reserpine act on noradrenaline vesicular uptake um, carriers, so it's a vesicular uptake inhibitor. Drugs like desperamine act on noradrenaline neuronal reuptake inhibitors. Fluoxetine is a serotonin neuronal reuptake inhibitor. And then propenicide acts typically on weak acid carrier inhibitors in the renal tube. So these are all examples of drugs under the carrier protein mechanism, and they are all important to note for your exams. Now, this picture is a picture of captopril. Captopril is an antihypertensive drug that has a mechanism of action interacting with enzyme. The particular enzyme that captopril interacts with is the enzyme angiotensin converting enzyme. This enzyme is responsible for the regulation of blood pressure. So captopril typically inhibits this enzyme, and in doing so, it would lower the blood pressure as a result. It's important to note that drugs classified under the mechanism of enzyme interaction could either be a competitive inhibitor of an enzyme or a non-competitive inhibitor of an enzyme. You remember this particular concept in your biochemistry module in the sense that competitive and non-competitive enzyme inhibition are different. Competitive enzyme inhibition involves the interaction of a substance with the active site of the enzyme, and as a result, the particular substance would compete with other substances that would want to bind to that enzyme or active site. For non-competitive inhibition involves substances that tend to bind to allosteric sites on an enzyme. They don't bind to the active site. Thereby, they are not competing with other substances that would want to bind at the active site. Another difference between the competitive and non-competitive inhibition is that competitive inhibition tends to be reversible, and the reversibility of competitive inhibition is just by increasing the other substances that would want to bind to the active site, whereas non-competitive inhibition tends to be typically irreversible. It's important to note examples of drugs that are classified as competitive enzyme inhibitors and non-competitive enzyme inhibitors for your exams. For the competitive enzyme inhibitors, we have drugs like the angiotensin converting enzyme inhibitors like captopril. We have drugs like the reversible anticholinesterases like the neostigmine, and we have allopurinol used in treating gout. For non-competitive enzyme inhibition, we have drugs that are classified as irreversible anticholinesterase, drugs like the organophosphate found in insecticides, cyclooxygenase enzyme inhibitors like aspirin, monoamine oxidase inhibitors like imipramine, and proton pump inhibitors like omeprazole. Now, for the rest of the module, we'll be focusing on receptors. The reason for us focusing on receptors is because receptors are the most common target sites for drug action in the body. So most of the drugs that we talked about, or most drugs present in the world, have their mechanism of action primarily on receptors. And as a result, it's important that we talk about what receptors are. Receptors, in terms of definition, are referred to as regulatory macromolecular proteins that are found either on the surface or within the cell, and they're involved in different forms of functions in the body. Now, how can we classify receptors? Receptors are classified based on five different criteria. We could classify receptors based on their pharmacological criteria. We could classify receptors based on tissue distribution. We could classify receptors based on ligand binding, based on transduction pathway, and also based on molecular cloning. Pharmacological criteria classification of receptors just involves the designation of receptors based on whether they are agonist or antagonist, whether they are selective agonist or antagonist. And this is the oldest form classical way we classify receptors. For classification of based on tissue distribution, just talks about the distribution of receptors across different tissue types. You have some receptors found largely in the CNS, some found largely in the PNS. We have some receptors found largely in the stomach, some in the heart, some in the lungs. And just based on how they are distributed, we could subclassify some receptors and designate them based on where they are found. Classification based on ligand binding involves the interaction of a receptor with a particular type of substance or ligand. And receptors could be named as a result of what particular ligand in history is typically known to be to have high affinity for this set of receptors as a result. So transduction pathway is the commonest way we classify um, receptors, is the modern way we classify receptors, and it's based on their mechanism of transduction, which we'll be talking about in the next couple of slides. And then finally, molecular cloning is the last form of criteria for classification. In this, we classify receptors based on their amino acid sequence and their three-dimensional structure. And this is more of the most, this is kind of the most recent form of classification for receptors, although it's not as common as the transduction pathway. The structure of a receptor is important for you to note before we talk about their relationship with pharmacology. Receptors are composed of two major domains. We have what we call the ligand domain and we have the effector domain. And the ligand domain is a domain that is responsible for recognition of specific ligands or drugs or molecules. So if a drug is going to be acting on the receptor, the particular part of the receptor that that drug would interact with would be the ligand domain. Ligand domain could either be found on the membrane of the cell or the cytoplasm. It could be intracellular or just be found on the plasma membrane. The second domain is the effector domain. Effector domain is responsible for the response or effects of the receptor after the particular ligand or drug has interacted with the receptor through the ligand domain. And once the ligand domain is activated, it would eventually interact with the effector domain, and the effector domain would undergo a conformational change and thereby causing the or producing the response or effect that we want the receptor to do. The effector domain could either be a channel or an enzyme, or it could be both. And we'll talk about this in terms of the different types of receptors. Receptors could have a channel, could have an enzyme as an effector domain, or they could be a combination of both. And there's one more thing that we should note about these two domains. Typically, we would have a scenario where, or receptors where these two domains are directly linked together or coupled, or we could have a scenario where these domains are separated. Either ways, once these domains need to interact once they are present within the receptor, and how the two domains tend to interact is by a process we call transduction or pathway or coupling. And we'll talk about this in the next couple of slides. If you recall from our previous set of slides, I made mention of the fact that we classify receptors based on five criteria. We will classify them pharmacologically, classify them based on tissue distribution, based on ligand binding, based on transduction pathway, and then molecular cloning. The photo classification I said is the commonest, and that classification, the transduction pathway classification, is how we tend to classify receptors into four different types. So the four types of receptors that we could see on the screen are classified or arrived at based on the transduction pathway. So these four types of receptors include the ligand-gated channel receptors, the G protein coupled receptors, the enzyme linked receptors, and the intracellular receptors. The reason why we classify each of these receptors is primarily based on the type of domains they have, where the domains are found, and then what type of transduction pathways tend to connect or link these domains. Remember that a receptor has two domains, the ligand domain and an effector domain. And the ligand domain could either be found on the membrane or in the cell or in the cytoplasm of the cell. We also remember that the effector domain could either be a channel or an enzyme or both. And finally, remember that we have different forms of transduction that we could have just based on how the ligand domain is linked up with the effector domain. Each of these different types of receptors are based on these different criteria, and we'll talk about each of them next. So this is a picture that captures in a nutshell the different types of receptors. From the right to the left, we have the ligand-gated receptor present on the here. Then we have the G protein coupled receptor. We have the enzyme linked receptor in C, and then the intracellular receptors in D. Starting with the ligand gated channel receptors, these receptors like have a ligand and effector domain. The ligand domain is typically located in the on the membrane of the cell. The effector domain is an ion channel, and both the ligand domain and the effector domain are directly connected together. There's a direct coupling or transduction between these two domains. So remember that these receptors tend to differ based on their ligand domain, effector domain, and transduction. And as shown in the screen above, the ligand-gated channels tend to have very unique features in those three aspects. The structure of the ligand-gated channel receptors are referred to as oligomeric, and they are an assembly of subunits of structures that are arranged around a central pore. The central pore will serve as the lumen by which the channels will be formed. Examples of ligand-gated channels include the GABA type A receptors and a drug that is used in work that tends to work on this particular type of receptor is the drug benzodiazepine. This is a picture of a typical ligand-gated ion channel. It's a receptor with a ligand domain found at the membrane. You can see the ligand domain present here, and an effector domain that is an ion channel. This is the rest of the effector domain here, ion channel. And remember that they are directly coupled, meaning that there's a link, there's a direct connection between the ligand domain and the effector domain, as you can see in this particular image. And how these receptors typically tend to work is that drugs would bind on the ligand domain, as you can see, the drug being the ligand here binds on the ligand domain. And once the ligand domain is activated, the ligand domain, due to the direct coupling to the effector domain, would activate the effector domain. Because the effector domain is an ion channel, the activation of the effector domain will lead to the ion channel being opened up. And as a result of it being opened up, we have ions going in or moving out of the cells. This is another picture of the ligand gated ion channel receptors. It's also important to note that another name for the ligand gated ion channel receptors is ionotropic receptors. So in case we don't want to call it ligand gated ion channel, to call it ionotropic receptors. The second type of receptors are G protein coupled receptors. These receptors also have a ligand domain, an effector domain, and a transduction pathway or coupling. The ligand domain is also found on the membrane, just as we have seen also in the ligand gated receptor channels. The effector domain, on the other hand, could either be a channel or an enzyme. Usually, it's both of them. So it has enzyme component alongside channel component. It's a mixture. It's not an either or situation, but uh, a combination of both. The transduction or coupling between the ligand domain and the effector domain is done by an intermediary. Note that G protein coupled receptors don't have a direct connection between their ligand domain and effector domain. What tends to serve as an intermediary connecting the ligand to the effector domain is the G protein. Hence, the reason why it's called a G protein coupled receptor. The structure of a G protein coupled receptor is referred to as being monomeric or dimeric, and the structure comprises of 7 transmembrane helix found within the membrane. Examples of receptors that are classified as G protein coupled receptors are muscarinic receptors, and drugs that act on muscarinic receptors will be drugs like atropine, acetylcholine, pilocarpine, etc. Here's a picture of the G protein coupled receptor. As you could see, the ligand domain being present at the membrane is not directly linked to the effector domain, which is an enzyme in this case. And what tends to link the ligand domain to the effector domain is an intermediary called G protein. This G protein here. If the G protein coupled receptor is going to be acting, the ligand or the drug would first of all bind to the ligand domain, as we can see here. Signal molecule there is the drug. It binds to the ligand domain and activates the ligand domain. The activation of the ligand domain will lead to the activation of G protein, and then G protein, alongside many mechanisms of G protein that we'll talk about next, would end up activating the enzyme, which is the effector domain. This is a picture of how the protein coupled receptors tend to work one more time. You have a ligand domain present here in green at the membrane of the cell. We have the effector domains elsewhere. The effector domain could either be a channel or an enzyme. In the case of this, we're taking it as an enzyme. And remember that since the ligand domain and effector domain are not linked, we need an intermediary to connect them or couple them together. And that intermediary is G protein. G protein is involved in the transduction pathway of the G protein coupled receptors. The G protein is a combination of different subunits of protein. We have an alpha subunit, beta subunit, and a gamma subunit. And G protein is always connected to a GDP. For the transduction or the function of a G protein coupled receptor, once a drug binds on the ligand domain, that ligand domain becomes activated. The activation of the ligand domain will lead to the activation of the G protein. And how we know that G protein is activated is that first of all, we have the GDP present on the G protein being converted to GTP. And once the GTP is um, once the GDP is converted to GTP, what happens is that we have the alpha subunit dividing and splitting from the beta and gamma subunit. And it's that alpha subunit connected to GTP that would activate the enzyme present within the effector domain. One very important point about the transduction pathway of G protein coupled receptors is the fact that the intermediary G protein does not work alone. G protein tends to have a combination of many other molecules that interact with it to eventually activate the effector domain of the receptor. And this set of molecules that interact with the G protein includes enzymes and secondary messengers. We have different types of G protein, which is also a different fact to note. We have 4 major types of G protein. This G protein includes GS, GI, GQ, and GO. And out of the 4, the 3 that you should really pay attention to will be the GS, the GI, and the GQ. And aside knowing this G protein, you should also remember that they have submolecules or assisting substances that tend to work hand in hand together with them to perform transduction. For the GS, for example, GS tend to work together with the enzyme adenyl cyclase and the secondary messenger cyclic AMP. GI tends to work with the enzyme as well, adenyl cyclase and cyclic AMP, but it does different things compared to GS. The GQ tends to work with the enzyme phospholipase C and the secondary messengers IP3 and DHA. I'll talk about how the G protein tends to interact with this set of substructures for it to perform transduction. Now, in a nutshell, this image captures for us the 4 different types of G protein and their mechanisms in performing transduction. For the GS and the GI, starting with the GS once it has been activated by the ligand domain of the receptor, that GS would act first of all by activating the enzyme adenyl cyclase. Once adenyl cyclase is activated, adenyl cyclase would lead to the production of a secondary messenger called cyclic AMP. So there's an increase in the amount of cyclic AMP present after adenyl cyclase has been activated. This cyclic AMP being the secondary messenger will now be the one to act on the effector domain. The effector domain in this case tends to typically be an enzyme, which is the protein kinase A enzyme. So important to note that for GI, this particular mechanism is reversed. For GI, once GI protein is activated, GI would inhibit adenyl cyclase, and the inhibition of adenyl cyclase will lead to a reduction in the amount of cyclic AMP present in the cell. And this reduced amount of cyclic AMP would eventually lead to the inactivation of the effector domain. The effector domain in this case being the protein kinase A. For GQ tends to act making use of different enzymes and the different secondary messengers. GQ typically acts on the enzyme phospholipase C. So once GQ is activated by the ligand domain of the receptor, GQ would stimulate this or activate this particular enzyme called phospholipase C. Phospholipase C is an enzyme that is involved in converting phospholipids in the plasma membrane to two different secondary messengers. The secondary messengers that is formed after phospholipase C is activated are IP3 and DHA. IP3 would act on ion channels, the ion channel, calcium ion channels, and lead to calcium influx. DAG, on the other hand, would act on an enzyme. The enzyme in this case is the protein kinase C and activate this enzyme. The joint effect of these two secondary messengers will lead to phosphorylation of different enzymes in the body and then performing the function of the particular receptor stimulated. The last picture on the screen is the picture of the GO receptor. Like I said, it's not really so important to note the function, but typically GO receptors, once it is activated, would act directly on ion channels. It could be a potassium channel, it could be a calcium channel. One more time, this picture captures for us the mechanism of the G protein coupled receptor, particularly GI and GS. Remember that the G protein coupled receptors, GI and GS, tend to make use of enzymes called adenyl cyclase, and the activation of the enzyme will lead to the increase in secondary messenger cyclic AMP. And once cyclic AMP is increased, it will activate the effector domain called the protein kinase A. And the protein kinase A would end up phosphorylating many enzymes in the cell, thereby leading to the function that we want to see for these particular receptors. This is the pathway again one more time. An example of a drug that could act through the G protein coupled receptor GS would be epinephrine. Epinephrine would act on a beta receptor. Beta receptors are receptors that are G protein coupled receptors and they tend to work with GS. So if epinephrine stimulates the ligand domain of the beta receptors that we can see here, that ligand domain could activate G protein GS, and then the GS will lead to the activation of the enzyme adenyl cyclase. Adenyl cyclase will lead to, activation will lead to the production of the secondary messenger cyclic AMP, and then cyclic AMP would lead to the activation of the effector domain, which is protein kinase A. Aside the adenyl cyclase and the cyclic AMP pathway, which is performed by GS and GI, we have the phospholipase and the IP3DH pathway, which is performed typically by GQ. Remember that if GQ is activated by the ligand domain, the GQ would interact with phospholipase C. Phospholipase C would lead to the production of IP3 and DAG, which are secondary messengers. IP3 typically act on calcium channels within the endoplasmic reticulum, leading to calcium influx. DAG tends to act on an effector domain that is separate called the protein kinase C, and protein kinase C would involve in phosphorylating different enzymes in the cell. One more thing before we move on to the next type of receptor. It's important to note that the G protein coupled receptors are also called metabotropic receptors. Now, this is different from the ligand-gated ion channels receptors, which are also called ionotropic. And it's important to note for your exam because they could ask you that. The third type of receptors are the enzyme-linked receptors. The enzyme-linked receptors typically have a ligand domain found on the membrane. The effector domain is an enzyme, and then the coupling between the effector domain and ligand domain is a direct coupling, meaning that they are connected directly. The structure of the enzyme linked receptors are single transmembrane helices linking extracellular receptor domain to the intracellular kinase domain. So the um, structure of the enzyme link receptors as explained here, it's just the structure of the ligand domain being extracellularly located and then the effector domain being intracellularly located, and the effector domain is typically a kinase, which is an example of an enzyme that is involved in phosphorylation. And examples of receptors that are classified as enzyme linked receptors are insulin receptors or growth factor receptors, and a drug that would work on this receptor will be insulin. The picture of an enzyme linked receptor. The enzyme linked receptor member would have a ligand domain and effector domain. The ligand domain is going to be extracellularly located, which is the ligand domain here. It's involved in recognition of different drugs or ligands, as you can see. And then the effector domain is present at the intracellular part um, of the receptor. And this is the effector domain. Effector domain, remember, is an enzyme, and this enzyme is typically kinase. And as you can see in this particular image, once the ligand binds on the ligand domain, what happens is that we have the enzyme, the effector domain, being connected together, and this connection will lead to the activation of the enzyme domain, and it can start to perform its activity as an enzyme. This is a picture that captures the mechanism of the enzyme linked receptors. You could have the drugs binding first of all to the ligand domain present at the extracellular site, and then that binding will activate the effector domain. As you can see here, there's an activation of the effector domain in the intracellular site. Because the effector domain is an enzyme and it's a kinase for that matter, the effect of the enzyme domain will be phosphorylation of different structures in the body. So there's phosphorylation occurring here, and that would lead to the mechanism or the response that we want this particular enzyme to perform. We have two different types of enzyme linked receptors based on the type of effector domains that they possess. The types of enzyme linked receptors we have are tyrosine kinase receptors and then the kinase receptors. This is just purely based on what type of enzymes are they possess. For tyrosine kinase receptors, the enzyme is the tyrosine kinase. For JAK-STAT kinase receptors, the enzyme there is the Janus kinase signal transducer activator transcription receptor. Final type of receptors we have are the intracellular receptors. These receptors have their ligand domain located within the cell. They're located intracellularly in the cytoplasm. The effector domain, on the other hand, is completely different from the receptor. The effector domain is found typically within the gene, found it as part of the gene transcription. And the coupling between the ligand domain and the effector domain is via DNA transcription. The structure of the ligand domain typically is referred to as a monomeric structure with separate receptors and DNA binding domain. And examples of receptors that are classified as intracellular receptors are steroid receptors, and drugs that work on these receptors include steroids. And this is a picture of the intracellular receptors. You could have the drug first of all entering into the cell to interact with these receptors, and it interacts first with the ligand domain. Ligand domain is shown in this particular picture as the triangle present here. Once the drug interacts with the ligand domain in the cytoplasm, the complex of the drug and the ligand domain would enter into the nucleus to interact with the effector domain, which is on the DNA. And as a result, this particular coupling would affect gene transcription. Now, the four types of receptors are captured in this particular picture, and very important to quickly note that these receptors, as we've talked about them, tend to also differ in terms of their onset of action. So the time scale for each of the receptors differs in the sense that the ligand-gated ion channels typically are very fast acting. Once a drug or a ligand binds on this particular receptor, the effect that we see occurs within milliseconds. The G protein coupled receptors are next in terms of pace. G protein coupled receptors, the effect tend to occur within seconds of the drugs or ligand binding to the receptor. For the kinase linked receptors or enzyme linked receptors and the nuclear receptors or the intracellular receptors, the timestamp tends to be within hours to days. And these are all examples. They're all examples shown within the uh, picture here to show different types of drugs that also work on these receptors. So before we talk about drug receptor relationship, just quickly want to make note of the other types of receptors that we could have. This is of very minimal importance, but you could be tested on it, and that is why I really want to touch on it. So we have three major types of receptors that we tend to classify that are not among the main classes of receptors. We have what we call sphere receptors, silent receptors, and orphan receptors. Sphere receptors are receptors that are typically unoccupied. And imagine a scenario where giving um, a drug, and that drug is acting on a particular site that contains 100 receptors. If we have 80 of these receptors being interacted by a drug, the remaining 20 will be referred to as a spare receptor because they are unoccupied. They are receptors that could easily get saturated if we're giving the maximum amount of dose possible. Silent receptors are receptors that are or protein that tend to bind to drugs or ligand but have no pharmacological response. Examples of silent receptors could be plasma proteins. Plasma proteins are proteins within the blood that just bind to drugs and carry them during distribution. Then we have the orphan receptors. Orphan receptors are receptors that are present within the body, but we have no idea about the ligand or the drugs that typically bind on these receptors. So they are receptors that we cannot really cannot really affiliate or associate a ligand to. Now we've learned everything we need to note about the receptors, but how do we connect the receptor to pharmacology? And this particular section of the slide will talk about the relationship between a drug or pharmacological agent and a receptor. Starting, we'll talk about what we call drug receptor theories. And this is not really high yield, but it's important to note that before we're able to arrive at the modern explanation behind a drug receptor relationship, we had previous attempts to describe the relationship between drug and a receptor. And as a result, we have numerous theories that tend to explain it. Right? Although we have just one that we tend to settle with at the end of the day. We have what we call the occupancy theory, which was like the first theory that they came up with that tend to explain the drug receptor theory or drug receptor relationship. The occupancy theory talks about the fact that the response produced by a drug and receptor relationship is proportional to the fraction of occupied receptors. So this one just states that the more receptors are being occupied by a drug, the more the response that we see as a result of the interaction between the drug and the receptor. We have the rate theory. The rate theory, on the other hand, talks about the response being proportional to the rate of drug receptor complex dissociation. And in this case, this one says that the duration of receptor dissociation determines whether a molecule is an agonist, a partial agonist, or an antagonist. The other theory, the third theory that they came up with was what they call the Stephenson's theory. Stephenson's theory talks about the fact that the response of a receptor in relation to the drug is proportional to the fraction of occupied receptor and the intrinsic activity. So this one is kind of a modified version of the occupancy theory. It's the occupancy theory together with a concept of intrinsic activity that we'll talk about very soon. Then we have the Arrhenius theory. The Arrhenius theory is the theory that talks about the response being a function of affinity. It talks about how strongly a particular drug is bound to the receptor, and that they're saying that that will determine the response. So drugs that have very strong affinity to the receptor, that are very tightly bound to the receptor, would have a greater response. So we say that maximal response are produced without 100% receptor occupation. So this one is kind of antagonistic to the occupancy theory. We don't really need to have 100% occupancy of a receptor to have the maximum response. The maximum response, according to the Arrhenius theory, is based on how tightly these particular drugs are bound to the receptors. Then there's the induced fit theory, which is the most common of the different theories, drug receptor theory. The induced fit theory talks about the fact that the response is a function of the degree of conformational change between the drug and the receptor, and that if a drug induces a conformational change on the receptor, like it forms an induced fit on the receptor, like a lock and key scenario, then that drug is referred to as an agonist. If a drug causes no conformational change, then the drug is an antagonist. Whereas if the drug undergoes a partial conformational change, then that drug is referred to as a partial agonist. We'll talk about what all this concept of an agonist, an antagonist, and partial agonist is about when we get to the next slides. The last theory of drug receptor relationship is what we call the macromolecular perturbation theory. And this theory just talks about the fact that the response of a receptor to a drug is by the function of the type of macromolecular perturbation that is possible. And this one states that either there's either a specific conformational perturbation present, which will lead to a biological response, or there's a non-specific conformational perturbation. This one is just saying that if you are having a conformational perturbation, then you're an agonist. If you're having a non-specific conformational perturbation, you're an antagonist. So the keyword in macromolecular perturbation is whether the type of perturbation that is occurring is specific or non-specific. And this kind of mirrors what is talked about in induced fit. The difference between induced fit theory and macromolecular perturbation is the fact that for induced fit, um, once you are able to undergo conformational change, you're an agonist, whether partial or full. If you don't undergo any, if you don't cause as a drug, if you don't cause any conformational change, then you're an antagonist. This is different from macromolecular perturbation in the sense that for macromolecular perturbation, specific conformation is referred to as an agonist. Non-specific conformation perturbation is referred to as an antagonist. More importantly to note for the drug receptor relationship is what we call drug receptor interaction. And this talks about four things that can or must be present for a drug and a receptor to have a relationship. So for a drug and receptor to have a relationship, the first thing that must occur was that that drug must have affinity to the receptor. It's very important. The drug that does not have any affinity to the receptor cannot interact with the receptor. And a drug that has affinity to a receptor is automatically referred to as a ligand. So ligands are drugs that or substances that can interact or has affinity for a particular receptor. The third principle or third property of drug receptor interaction is what we call intrinsic activity. Now, this one is not a must. All right, the first two are a must. The drug must be for a drug to have a relationship to the receptor. A drug must have affinity and must be a ligand. But it's not in all cases that the drug must have intrinsic activity, which is the third principle. We'll talk about that very soon. And then the last principle is the principle of specificity. This also is not a must. It's not all drugs are specific to a particular receptor. Explain each of those different concepts one by one. Ligands are referred to as as any molecule that tends to attach selectively to a particular receptor or a site. Ligands could either be an endogenous substance produced by the body, for example, acetylcholine or adrenaline already produced by the body, or drugs. Drugs or could also be referred to as a ligand. The idea is that so far the ligand is able to, or the molecule is able to bind to a receptor, has affinity for the receptor, is able to attach to the receptor. That molecule is referred to as a ligand. Now, in terms of how strongly a ligand tends to attach to receptor, we have different types of receptor binding. We can have a reversible receptor binding or irreversible receptor binding. And this by virtue of the fact that we have different bonds being created between the drug and the receptor, which produces different forms or types of binding. For the reversible binding, the type of bond that is formed between the drug and the receptor is a weak bond. And examples of forces that tend to form weak bonds are ionic forces, hydrogen bond, and then van der Waals bond. And the effect or that is produced when a drug binds to the receptor using a reversible binding is usually short-lived. For irreversible binding, the bond formed between the drug and the receptor tend to be very strong, and this bond tend to be formed by covalent bonds. And as a result, the effect that is produced between the drug and the receptor tend to be prolonged and even irreversible, as the name implies. Let's talk about the second concept of drug receptor interaction, concept of affinity. And like I said, every drug that must have a relationship with the receptor must have affinity for that receptor. Affinity refers to the tenacity of a drug to or a ligand to bind to a given receptor. Just think about affinity as the glue in relationship between two people. See a male and a female having affinity for one another. The tenacity, the strength of that affinity will determine how well that particular drug or will bind to the receptor, or how well that relationship would be. Now, the third property of drug receptor interaction is intrinsic activity. Intrinsic activity is the capacity of a ligand to induce a functional change in a given receptor in a way that that produces a particular effect. Note that when we're talking about drug receptor theories, I made mention of the fact that the particular theory that we settle with in currently now in pharmacology is the induced fit theory. And the induced fit theory states that the response of a receptor and a drug is purely based on the ability or inability of the drug to cause a conformational change. Now, a drug that is able to cause a conformational change is referred to as a drug with intrinsic activity. A drug that is unable to cause a conformational change is a drug that lacks intrinsic activity. Note, it's not required that all drugs have intrinsic activity. A drug could have affinity. A drug must have affinity, but it's not necessarily that a drug has intrinsic activity, as we would see later on when talking about drug receptor outcome. Think about intrinsic activity as a male causing butterfly effect on the female, being the receptor, the male being the drug. The drug would cause an effect or conformational change on the receptor, and that is akin to causing a butterfly feeling in the belly of the female when the female sees the male. Remember that when we're talking about relationship, we're talking about affinity being present. Affinity must always be present for a relationship to occur. And beyond affinity, you could have intrinsic activity in which one partner would make the other partner to feel a certain type of way um, in just by virtue of their presence. The last property of drug receptor relationship is specificity. Specificity talks about the ability of a drug to interact with a single type of receptor being expressed at a particular cell. And it kind of is an exclusive property in the sense that you have a drug only working on a particular receptor and not on others. It's also important to note that not all drugs tend to follow this particular property of rule. So we have drugs that have specificity, we have drugs that are non-specific, we have drugs that bind to multiple receptors present within the body. So once a drug has established a relationship with the receptor, meaning that the drug has affinity for that receptor, the drug hence is a ligand. The drug may or may not have intrinsic activity or may not be specific. Once the relationship has been established, there are four possible outcomes that we could have once the drug binds to the receptor. The four possible outcomes could be that the drug could be having a full agonist effect or response. The drug would have a partial agonist response. The drug could be having an inverse agonist response, or the drug could be an antagonist. A full agonist is a drug that tends to activate a given receptor and produces the maximal effect. It's a drug that has affinity and has intrinsic activity. And the combination of both the affinity and intrinsic activity produces a conformational change that will lead to a response that is 100%, that is 1. Think about a relationship as we could see on the screen of uh, Daphne and Simon or Simeon in the popular movie or series. In this particular relationship, both of them have affinity for one another, and both of them have intrinsic activity for each other. And the type of love or relationship or affection that we see is an affection that is maximal. For the partial agonists, these are drugs that activate a given receptor but produce submaximal biologic effect. The key word here is submaximal biologic effect. So the drugs that are classified under this particular type of outcome are drugs that have affinity and have an intrinsic activity. And the combination of both of them will lead to a partial conformational change on the receptor. And this partial conformational change will lead to a response that is below 100%. So the response is above 0, so it's something, but it's not a full response. The partial response is between 0 to 1. Now, I think tend to akin this particular type of outcome to the relationship between these two popular individuals, Amy and Sheldon in Big Bang Theory. Remember that these two people have affinity for one another, but their intrinsic activity might not be totally maximal to the point in which the type of affection that we see is a submaximal affection based on other people's criteria or judgments. Inverse agonists are drugs that tend to activate a given receptor, but instead of producing the known effect of that receptor, they tend to produce a negative biological effect or opposite effect to that of the full or partial agonist. So think about an inverse agonist as a drug that tends to have an affinity for the receptor, has intrinsic activity, but the type of intrinsic activity that it's having is going to be a negative conformational change. Thereby, we see that the combination of affinity and intrinsic activity of an inverse agonist is less than zero but greater than -1. I think about a relationship. I'm thinking about a popular movie, Blood Sisters, where these two individuals were getting married. They have affinity for each other. Obviously, that's the reason why they're getting married. But the type of intrinsic activity was very toxic. They were in a toxic relationship, and the man was beating up the woman. The woman ended up killing him. So you can see that it had a negative effect. The love or the affection that we're expecting was not the outcome which we eventually arrived at. The final type of drug receptor outcome is antagonists. Antagonists are drugs that interact with a given receptor but have no particular response. They produce no response at all. In this particular set of outcome, these drugs are drugs with affinity but no intrinsic activity. They lack an intrinsic activity. And as a result, we say that the affinity and the lack of intrinsic activity equals to a response of zero. So these drugs that just typically occupy space within the receptors, just bind the receptors, but they don't cause any conformational change. Thereby, they don't produce any effect at all. And thereby, they're just occupying space. It's important to remember that antagonists are not doing the opposite. Right? They're just occupying space, but they are preventing other ligands from acting on the receptor. Thereby, they are preventing other ligands from producing a positive response. I think about the relationship and I think about the relationship between these two individuals, Kate and Toby, in the movie This Is Us, as one of my very favorite series. And in this relationship, they have affinity for each other, but the love has probably died. Probably they're just together because of their son. They are not having any toxic relationship. Everything is just indifferent between two of them, but the affinity still remains regardless. I just think about that. I think about a relationship without any necessary um, uh, activity or excessive affinity or even small affinity between them. Just everything just indifferent between them. Now, this picture captures those four types of outcome that we talked about. You could see that we have the basal activity already present here. Basal activity is between 40 to 20%. They say 30%. When we give an antagonist will not do anything at all. It just blocks the receptor. Thereby, the basal effect remains the same. When we give a full agonist would cause a conformational change on the receptor and lead to a maximal response, 100% response, as you could see here. A partial agonist would also cause a conformational change, but it leads to a partial conformational change, and the response we see is a partial response. You could say that the response here is started at between 60 to 40, about 50% of the response. And then the inverse agonist will do the opposite of what the full and partial agonist will be doing. It's going to be reducing the basal activity of the particular receptor. You can say that the basal activity has dropped from 30 to 0 or a less than effect or negative effect. Final concept we're talking about will be drug receptor regulation. And this is important to note that everything in the body tends to be regulated. Drug receptor interaction also is regulated. We don't want it in an area where a drug is overstimulating a receptor or over inhibiting a receptor. Thereby, we have what we call upregulation and downregulation. I will talk about that next in a couple of slides. So upregulation refers to an increase in the number of receptors on a cell, and this is primarily based on the fact that it's either that the drug or the substance that tends to stimulate that receptor is deficient, or we have an antagonist that's actually blocking that receptor. So either of those cases can lead to an upregulation of a receptor. So examples could be if we have a depletion of noradrenaline or treatment, or if you are giving a adrenergic antagonist. These two things will lead to the tissues being super sensitive to noradrenaline, and then the amount of the receptors of the um, receptors to noradrenaline would also increase, thereby leading to an upregulation. Downregulation seems to be the reverse. In downregulation, we have a decrease in the number of receptors or a desensitization, refractoriness, or tolerance of the receptor occurring. And this is due to the fact that you could have a repeated administration of a particular drug, and that repeated administration would lead to excess exposure of the receptor to the drug. The receptor will get tired of the drug, and the receptors will start to downregulate, start to reduce in number and reduce the sensitivity. So this is one of the reasons why we could have a scenario called physiological or pharmacological tolerance occurring in maybe an illicit drug. If you're using an illicit drug and we're exposing our receptors to illicit drug continuously, what will happen is that the receptors will down-regulate and will be needing greater dose or greater amount of the drug to achieve that particular type of stimulation we were achieving before initially. So repeated administration of a drug like repeated administration of an adrenergic agonist in asthma can lead to downregulation of receptors and thereby would need to increase the dose to attain the previous effects that we were getting. This picture just captures the concept of upregulation and downregulation. The idea behind upregulation is that there's an increase in the amount of receptors and an increase in sensitivity to the receptors. So two of those things are true. As you can see in this picture, the receptors initially was just two, but as you progress with time, the amount of receptors present on the cell will increase the number. That is upregulation. Down regulation is the reverse. In down regulation, we have an increased amount of receptors initially, but due to excessive exposure of the drug to the receptors, we have the receptor number reducing. It's also important to note that aside the receptor number reducing, you also have the sensitivity of the receptor also reducing. So the receptor becomes desensitized. And that concludes our module on pharmacodynamics 1.